Hi, today's topic is on syndrome of inappropriate antidiuretic hormone, or SIADH, which is another pituitary disorder. SIADH is a problem in which ADH is secreted even when the plasma osmolarity is low or normal. A decrease in plasma osmolarity normally inhibits ADH production and secretion. The increased release of ADH causes water retention, water intoxication, and dilutional hyponatremia, serum hyperosmolality with normal renal function. The increased plasma volume increases the glomerular filtration rate and inhibits release of renin and aldosterone, which results in increased sodium loss in urine, also leading to greater hyponatremia. There are many causes for SIADH. It is caused by many pathological conditions and certain drugs. Malignant tumors like small cell lung cancer, Hodgkin's lymphoma, non-Hodgkin's lymphoma, pancreatic, duodenal, and genitourinary carcinomas are capable of producing, storing, and releasing ADH independent of a normally functioning hypothalamus and feedback mechanism. Pulmonary infections like viral and bacterial pneumonia, lung abscess, mycosis, chronic lung diseases can also contribute to SIADH. CNS infections or trauma, skull fractures, CVA, brain tumor, and systemic lupus erythematosus are other causes. And it can also be drug-induced, namely chlorpropamide or diabinase, carbamazepine or tegretol, opioids, vincristine, which is a chemotherapy drug, tricyclic antidepressants, and opioids can also cause SIADH. Clinical manifestations. The early manifestations of SIADH are related to water retention and oliguria. GI disturbances such as loss of appetite, nausea, vomiting may occur first, and abdominal cramps are seen. In patients with SIADH, free water and not salt is retained, and dependent edema is thus not usually present. Water retention, hyponatremia, and fluid shifts affect central nervous system function. When the serum sodium level drops below 130, the patient may have lethargy, headache, hostility, disorientation, and a change in level of consciousness. Manifestations can progress from lethargy and headache to decreased responsiveness, seizures, coma, and decreased deep tendon reflexes. Signs and symptoms of fluid overload like weight gain, hypertension, crackles in the lungs, distended neck veins, a taut skin, and increased output less than intake is also typically seen and has to be monitored. Fluid retention can cause excessive ADH increases. Fluid retention is caused by excessive ADH, which increases the permeability of the distal tubules and the collecting ducts, which leads to water reabsorption into circulation, which further results in decreased serum osmolality less than 280 and hyponatremia. Diagnosis of SIADH. A serum osmolality much lower than the serum osmolality indicates the inappropriate excretion of concentrated urine in the presence of dilute serum. Decreased hematocrit and BUN levels are seen. Immunoassay of ADH hormones may be done, and based on the analysis of urine and serum electrolytes and osmolality, dilutional hyponatremia with sodium less than 134, low serum osmolality less than 280, high urine osmolality, and high urine specific gravity more than 1.025 is seen. Increased urine sodium level is also seen in SIADH. Management of SIADH. Medical interventions for SIADH focuses on restricting fluid intake, promoting excretion of water, and replacing any lost sodium, and interfering with the action of ADH. Fluid restriction is essential because fluid intake further dilutes the plasma sodium levels. In some cases, fluid intake may be kept as low as 500 to 600 mL per 24 hours. Dilute tube feedings with saline rather than plain water, and use saline to irrigate GI tubes. Mix drugs to be given by GI tube with saline. Measure Eisenhower's daily weights to assess the degree of fluid restriction needed. A weight gain of 2 pounds or more per day or a gradual increase over several days is a cause for concern. A 1 kilogram weight increase is equal to 1,000 ml fluid retention, meaning 1 kilogram is equal to 1 liter. The patient is uncomfortable during fluid restriction. Keep mucous membrane moist by offering frequent oral rinsing, and remind the patient not to swallow rinses. Sugarless chewing gums may also help to reduce thirst. Fluid restriction should result in reduction of weight and a progressive rise in sodium and osmolality. In severe cases of hyponatremia, IV hypertonic saline solution is infused slowly to avoid too rapid a rise in sodium, and fluid restriction of only 500 ml is given. A loop diuretic like furosemide or Lasix may be used to promote diuresis only if the serum sodium is at least 25 MEq. If it is at least 125 MEqs, because it may cause further loss of sodium as well as potassium. Declomycin, an antibiotic used to treat acne, blocks the effect of ADH on the renal tubules. Vasopressin receptors antagonists like tolvaptan and conivaptan are used to treat euvolemia, hyponatremia in hospitalized patients. That's normal urine output, but still patient is hyponatremic. The patient on tolvaptan and conivaptan should be closely monitored to prevent rapid correction of serum sodium. Surgical intervention includes hypophysectomy. The nursing diagnosis for a patient with SIADH includes excess fluid volume related to increased ADH secretion, risk for injury related to hyponatremia and fluid volume excess, interrupted thought processes, acute pain, imbalanced nutrition less than body requirements, fatigue, and deficient knowledge. The nursing assessment includes determining if the patient had any recent nervous or pulmonary system infections, tumors, or increased intracranial pressure. Obtain a list of the client's medications, and also monitor for response to therapy to prevent fluid overload from SIADH from becoming worse, leading to pulmonary edema and heart failure. Any aged patient is at risk, especially the older adult or one who has coexisting cardiac problems, kidney problems, pulmonary or liver problems. Monitor for signs and symptoms of hyponatremia, including headache, confusion, muscle spasms, seizures, nausea, vomiting, and abdominal cramps, and for signs of fluid volume excess, including tachycardia, tachypnea, weight gain, crackles, jugular vein distension, pulmonary edema. The monitoring of the neurological symptoms, as well as close monitoring of the fluid volume excess and resulting neurological changes, should be done every 1 to 2 hours. Pulmonary edema can occur very quickly and can lead to death. Other nursing interventions, including fluid restrictions from 500 anywhere from 500 to 1,000 ml per 24 hours, accurate intake and output, and daily weights. Administer IV fluids cautiously, especially hypertonic saline solution, 3% to 5% saline, should be administered very slowly and cautiously to prevent further fluid overload, pulmonary edema, and heart failure. Monitor for increased fluid overload at least every 2 hours. Monitor for subtle neurological changes such as altered level of consciousness and muscle twitches, seizure precautions to be in place, and reduce overstimulation. A patient with SIADH who is hyponatremic but alert and oriented, the neurochecks can be performed every 4 hours, but if the patient has a change in the LOC, the neurochecks are to be done every hour. This nursing intervention focuses on monitoring response to therapy, preventing complications, teaching the patient and family about fluid restrictions. The evaluation and outcomes of the care of the patient with SIADH is to determine the client response to treatment. Have the fluid and electrolyte values normalized? Has there been a loss of weight? Have complications occurred? Is the client able to verbalize an understanding of instructions given, the medications, fluid restrictions, sources of water and sodium? Is the client compliant with fluid restriction guidelines? The next is hypophysectomy if there is need for a surgical approach for the management of SIADH. So hypophysectomy is removal of the pituitary gland through the transsphenoidal approach. It's elimination of the excess secretion of the hormones and restoring normal endocrine function, preventing complications. Preoperatively, the patients allow clients to verbalize their fears. Also explain that the nasal packing will be present for 2 to 3 days, during which time mouth breathing has to be practiced. A mustache dressing will be there and a drip pad under the nose to monitor for any leakage of CSF fluid. And also instructions regarding avoidance of increasing ICPs has to be discussed, which could delay healing. Monitoring of vital signs and neurological status needs to be done every 1 to 2 hours. Instructions to avoid vigorous coughing, sneezing, and straining at stool is to be given to prevent CSF leakage. And avoid toothbrushing for at least 10 days to prevent disrupting the suture line. Monitor for any postnasal drip or nasal drainage, which could indicate leakage of CSF. If the glucose was more than 30, it could indicate CSF. CSF leaks increases risk of meningitis, and leaks usually resolve within 72 hours with elevating the head of the bed. Elevating head of the bed avoids pressure on the suture lines and decreases headaches. So that would be the best position for these patients. Monitoring neurological status, pupillary response to detect neurological complications. Monitoring electrolyte values for temporary diabetes insipidus because of the loss of ADH stored in the posterior pituitary. Monitoring intake and output, serum and urine osmolality, and administering analgesics are done for these patients. Continue to monitor the for any CSF leakage. Bed rest and spinal tap may be done to reduce the CSF pressure. Any monitoring for complications, including diabetes insipidus, any signs of infection, and increased ICP is continued. Daily self-management regimen and frequent checkups are important. Develop strategies to reduce stress, and avoiding bending over from the waist and straining to have a BM for up to 2 months is to be taught to the patients. Vasopressin for fluid balance, thyroid, cortisone, and gonadal hormones may have to be replaced if the anterior pituitary gland is removed. In summary, SIADH results from abnormal production or sustained secretion of ADH, and the usual cause is a tumor or lung cancer. And SIADH is characterized by fluid retention and dilutional hyponatremia. And the treatment, we also looked at the treatment and the surgery, which is hypophysectomy for these patients.